Welcome to the webinar, Building Back Better, Leveraging Conflict Disaster Solutions to Develop and Scale Public Mental Health in Liberia. My name is Monica Ruiz Casares, and I'm an Associate Professor of Psychiatry at McGill University and coordinator of the Global Mental Health Research Seminar in the Faculty of Medicine. I will be the moderator for the webinar today. With support from the McGill Global Health Program, the Quebec Population Health Research Network, and the Sherpa University Institute, our webinar series expands the training that is offered in the McGill Summer Program in Social and Cultural Psychiatry. We're hoping that through these multilingual webinars, we will help raise awareness of mental health disparities around the world, exchange social, cultural, and critical research on global mental health, and build bridges across languages, across sectors, and geographical locations. We're very happy to share this space with you. Now, before I introduce our speaker for today, let me highlight a few important features of this platform that can help facilitate your participation. If you're joining us directly from your computer or the VoiceBoxer mobile app, notice that you can select your language of choice, English or French, at the bottom of your screen. Your microphones are all muted, but you will still be able to send questions for the speaker at any time during the presentation in any language using the general chat box underneath my image on the screen. You cannot see the presenter or chat if you are connecting through a cell phone though. For any technical issues during the webinar, you can contact the VoiceBoxer support team by clicking on the question mark icon on the bottom left-hand corner of your screen. Now let me introduce our speaker. Dr. Janice Cooper is a senior project advisor in global mental health with the Carter Center, and between 2010 and 2018, she led its Liberia Mental Health Program. Formerly, she led the Coalition for School-Based Primary Care, the Minnesota Children's Mental Health Division, and Columbia University's National Center for Children in Poverty. She was on the Institute of Medicine's Committee on Clinical Trials during the 2014-15 Ebola outbreak and the Lancet Commission on Global Mental Health in 2018. We're honored to have her with us today and look forward to her presentation. I will now pass the floor to you, Janice, to get us started.
Great, thank you very much. And I am delighted to be here and delighted to talk to you about my work and the work of the Carter Center Mental Health Program in Liberia. Sorry, let me just go back. So I wanted to start by saying a little bit about the framing and the assumptions made within the framing. First, that when we began this work in 2009, 2010, we thought about what were the needs given the complex post-war situation that we faced in Liberia. And so we thought about the need for building capacity for mental health. We had at the time one Liberian psychiatrist. We had very few personnel that were trained in clinical mental health services and no psychologists to really speak of. And so we knew we had to build a capacity that was an indigenous capacity to meet the mental health needs of the population. We also knew that we needed to address stigma associated with mental health, and I'll talk more about that. And that the other pillar was around policy and legislation. And so that's the framework we began our work with. So I will kind of do some fast tracking so that we have an opportunity for questions and for discussion. So between 2010 and 2014, which I kind of labeled the pre-Ebola virus disease part of the work, we were focused on building the mental health capacity of our mid-level providers. And in particular, since we did not have a cadre of psychiatrists or psychologists. We really focused in on providing this 6-month post-basic training program where people with clinical skills could expand those clinical skills to clinical mental health and also attain skills in psychological interventions. We're very keen to make sure that our anti-stigma program was as comprehensive as it could be, and so we targeted journalists, religious and traditional leaders, healthcare workers, law enforcement, pharmacists, and the general population. And I can talk more in detail about what those anti-stigma training programs look like if you have questions about them. Before Ebola, we also had the fortune to get funding from Grand Challenges Canada to do a program with 3 countries, Liberia, Nepal, and Uganda. And the idea with that was that the 3 countries would have one thing that they could contribute to the other country as being novel to the work that they were doing. And so in our program, we called it Mental Health Beyond Facilities. We targeted Sino County, and that was our intervention county, and 2 neighboring counties were the counties who are our comparison counties. And basically with that program, we were focused on trying to build a system of care in that community that was very far from Monrovia, which is the capital, and from a lot of commercial development. So there was a lot of farming going on there, and it was one of the counties. In fact, in terms of health indicators, it was one of the worst health indicators in the country. We also sought to develop local and indigenous-inspired research. So we worked on the creation and the incubation of an organization that's now called the Liberia Centers for Outcomes Research in Mental Health. It's a partnership between the Carter Center, the John F. Kennedy Medical Center, which is our major medical center here in Liberia, and the government of Liberia. We currently support and originally incubated an organization called Cultivations for Users' Hope, which is a mental health service organization, and we provided support to the ministry as it developed policy. Sorry. So let me talk a little bit about some of our stigma strategies that we had pre-Ebola and then how they were heightened. So training of journalists, supporting public information campaign in that space, training lay health workers, family members, and caregivers around stigma, and then supporting the creation and support for consumer-run organizations of persons with lived mental health experience. So before Ebola, we had 166 mental health clinicians, and essentially they were spread around the country. The red, white, and blue represents the flag of Liberia, very similar to the U.S. flag, except we only have 1 star as opposed to the 52 stars in the corner. We also have and those people that are in the big figures represent at least 10 mental health clinicians. It was a way for us to distinguish on that map what the landscape is. So you see that there are counties that have very few mental health clinicians, and then around the center, Montserrado, Monrovia, Margibi, those counties have many more mental health clinicians. So I'm going to fast forward to we had Ebola, and then we were declared Ebola free. And at that point in Monrovia, there was a converging of the 3 countries that have been affected in West Africa by Ebola: Guinea, Liberia, and Sierra Leone. And out of a meeting with major stakeholders, including WHO, the World Bank, major funders of healthcare, came a document which is on my left and your right, which is the guide for program planners for mental health and psychosocial supports in Ebola outbreak. And I'm told that it is being used in the current outbreaks that we have. I wanted to point you out to another document that's particularly pertinent for the work that we're doing now. We're focused on child and adolescent mental health in Liberia, and so it was important for us to develop modules that were specific to that population. So this is the Family Psychoeducation module. It's used in community-based mental health. It's used both by mental health clinicians as well as social workers and people trained in psychosocial interventions. This is the child adaptation of a curriculum that we originally developed for the general population. So the real focus of our child and adolescent mental health clinician program, and indeed the mental health clinician program that preceded it, was developed by Dr. Gail Stewart, who used to be the chair of the School of Nursing at the University of South Carolina Medical Center. And it was based on her textbook, Principles and Practices of Psychiatric Nursing. She came here and developed the curriculum with Liberian nursing professionals, both at the nursing school level as well as practicing nurses. The other component is the Family Psychoeducation Manual, which is the child adaptation version. Other parts of our training come from MHGAP, Mental Health Global Action Plan, both the humanitarian guide, which we use particularly after Ebola, as well as the intervention guide and the new intervention guide, as well as the child intervention guide. And so after Ebola, we really looked at WHO's Building Back Better as a strategy for how we might emerge out of this emergency as a stronger mental health system and as a stronger mental health program. So let me talk to you a little bit about kind of what our needs were. And some of you may be familiar with Tim Bruckner's work on the mental health workforce gap in low and middle income countries. So before Ebola, based on Bruckner's estimates, we needed 40 psychiatrists, and we only had one that was practicing, who had been practicing for many years before. We needed 380 psychiatric nurses or physician assistants, and at that time, we had 166 that were practicing. And we needed approximately 336 psychosocial workers. That would be your certified or clinical social workers, that would be your psychosocial workers, and that would be your lay counselors. And we had roughly around 200 at different levels, the bulk being people who had been trained as psychosocial workers either during the war or immediately after the war. So what we thought is we needed to use the opportunities we had to try and scale initiatives post-Ebola. And how could we build on the work we had done? So we had the work that we had started with Mental Health Beyond facilities that had been funded by Grand Challenges Canada that really looked at a pronged approach, making sure that we worked with consumers of mental health services, persons with lived experience, not only that they got their medicines and they got into treatment, but also that they had avenues for livelihood, avenues for engaging in the sector. And because of the stigma, many times, many of them were unemployed and ostracized in many cases in the community. We knew we wanted to build off the mental health clinician training program. We were approached by the World Bank about trying to do a post-Ebola intervention. And we wanted to rely on the collective planning of the NGOs and the INGOs that had been part of the Ebola response. And so the idea was that we had made some inroads to respond to emergency, and now how could we make sure that we shored that up? How could we make sure that we strengthened the system of care? You have to be cognizant of the fact that during emergencies such as Ebola, sometimes donors will spend 5, 10, 15 times the amount of money that was ever spent on just dealing with the response, as opposed to what was spent in dealing with the strengthening of the system of care. And that's what we saw with Ebola. So during that period, we were able to train different cadres of workers, over 800 different cadres of workers. We thought that at the very base, the lowest levels, we wanted to make sure that there was training in anti-stigma, in how to respond to acute stress, grief, and how to refer to appropriate clinicians and healthcare workers. So for our general community health volunteers, who are our general community health workers, we provided training for them in referrals and anti-stigma, but also in psychological first aid. For our mental health clinicians, we wanted to shore up the training that they had already gotten. For the social workers, we provided psychological first aid as well as psychosocial intervention training. And for health service users, we were interested to make sure that they had anti-stigma training, especially persons with lived mental health experience, training around how to manage their stress and how to seek services. For our mental health clinicians, I'll talk more about all of the training that we provided for them, in addition to the acute stress, grief, and referral training and the anti-stigma training. And then we try to reach teachers, religious and traditional leaders as well, because they were part of our system of care. And so just a quick reference to our religious and traditional leaders. Oftentimes, when persons have severe mental illness or they're in crisis, they're often taken in our settings to churches or to prayer camps or to religious leaders for treatment. So it was important for us to build on some of the learnings we had from our Grand Challenges Canada in Sino, where we had engaged religious leaders. And that picture is a picture of religious leaders coming together to talk about mental health in Sino. The Carter Center also has worked with police, law enforcement, and immigration. In particular, we worked with them around crisis intervention training. CIT is an evidence-based training that has been used widely in the United States and also in Canada, I believe. I recently reviewed a CIT paper from Canada. And we had trained law enforcement personnel and mental health clinicians in crisis intervention training, how to intervene when someone was in a mental health crisis that could be dangerous to themselves and to others. Heretofore, many times the police or law enforcement would be called to intervene, and the intervention would often be inappropriate and may result in harm to the user of mental health services or to persons around them, especially if a person was displaying signs of being dangerous. And many people did not have the tools to de-escalate a person with lived mental health experience when they were in crisis. And so we embarked on a training to train as many law enforcement officers as we could. So at this point, there are over 120 law enforcement officers that have been trained in crisis intervention training in Liberia. We're now in the process of embedding it into the pre-service officer training. And we have trained mental health clinicians to work alongside them. And we've done, as I said, a couple of peer-reviewed articles that reference that training, and I'm happy to send you citations if you are interested. This is just a case right now, and one of the depiction in the picture is what to do in the case of de-escalation of a person with mental illness or a person with epilepsy, which often is a case where the community gathers around the person, and it's often very traumatizing, both for the person that's having the episode as well as for people in the community. Sorry, I just went back too far, so let me go back one step. So we've trained certified mental health clinicians through this program, and this is just a depiction of where they are scattered around the country, so you have an idea of the locations of them. And we're now in the phase where we've turned that program over to the Ministry of Health, and they've run their first cohort. So you can see how they're distributed. Now, this is the child and adolescent mental health clinicians, and what we've done with them is to make sure that they continue to receive ongoing in-services as we try to roll the program over into the School of Nursing. So for the World Bank program in particular, where right after Ebola, we were charged with not just supporting the service of care for delivery, but also supporting the delivery of direct services. Over 20,000 beneficiaries benefited from the service delivery at that point. Half of them, more than half of them, were female. Many of them had severe mental illness. Many of them had not accessed services before. We engaged in, and I can talk more about that, with two counties where we're heavily involved. There was the whole issue of engaging in community healing dialogues. There had been a lot of mistrust among communities with regard to Ebola. There was a lot of accusations with families. If there was an index family in the community, oftentimes that family was ostracized, and neighbor was pitted against neighbors. Neighbors accused other neighbors of bringing Ebola into the community. So there was a need for a lot of community healing, and I can talk about how those dialogues went and the nature of those dialogues. We also engaged a number of personnel in the community in community mental health promotion. We opened up with external funding. We also opened up 7 school-based mental health clinics. So they provided both health and mental health clinics, and mental health clinicians are both nurses and PAs, so they already have the health training, and we add the mental health training. And so they were able to provide school-based health services. They were able to support parent support groups. And in the community, we were able to support, the mental health clinicians were able to support peer support groups, as well as increase the number of referrals that came from community health workers. This is an opening of one of our school-based clinics. At the bottom, you can see with funding from UBS, we were able to open up a school-based clinic that provided both health and mental health services, and it was just like a regular clinic, except it was only accessed by children and when their parents came in for groups by their parents. We also made sure that we reached out to nurses and PAs who were in the communities around the schools where we had clinics, and provided specific training for them, because what we were interested in was to make sure that out of school hours and in the communities that these children and their families frequented, those clinics also had access to mental health services. One of the things that we were very cognizant of in our work was that Liberia, as a result of war and the trauma as a result of the war, we have high levels of sexual and gender-based violence. And we wanted to make sure that mental health clinicians could be an added resource with specific skills for those who work in our SGBV clinics around the country. And so we trained mental health clinicians, all the mental health clinicians, whether they worked in the SGBV setting or not. We trained them to be able to provide services to mostly women and children who had experienced sexual violence. And in the picture, you see the lead for SGBV work in Liberia. She was our lead facilitator as well. The other thing I wanted to quickly talk about in our anti-stigma work is the work that we've done with journalists. So we've trained over 120 journalists to be able to report responsibly in a stigma-free and stigma-reducing way about mental illness. Oftentimes, prior to the training we've done with journalists across the country, we had a situation where you would pick up a newspaper and there would be a front page story, and it would be titled something like "Crazy Man in the Street," "Crazy Man Eating from the Dirt," those kinds of stories, and a picture of the person. Highly stigmatizing, further exacerbating the lack of access to healthcare services for persons with lived mental health experience. And so we worked on training our lead journalists across the country so that they were able to report responsibly. They took it a step further. They've started training community journalists in all the different, for community radio and community press. They also have trained student journalists at the University of Liberia and other schools of journalism so that they can report responsibly when they report on mental health. We want them to put mental health on front stage because we want our lawmakers and we want our policymakers to be cognizant of the need to continue to improve mental health services. We want persons with lived experience to have their views expressed as well in the newspaper, and we want their triumphs to also be exalted as with others. And so we want them to be in the newspaper and in the news, but we want it to be done in a stigmatizing and non-stigmatizing and non-discriminatory way. This is just a snapshot of some of the care that we provided in the school-based services that we have in both Kakata, and which is in Margibi County, is a neighboring county to Montserrado, which is where Monrovia is and where the capital is. And you can see we have even split between girls and boys usually. We've contributed to and used some guiding documents. I just wanted to talk a little bit about that. We're on our second mental health policy and strategic plan. We're going to start planning now with the government of Liberia and partners in Liberia for our next policy and strategic plan that lays out the service delivery system and how we expect it to improve. We also were instrumental and worked with the Ministry of Health partners and persons with lived experience to ensure that the legislature passed our mental health law. And right now we're in the process of taking that law and breaking the statutes down into rules and regulations, and I can speak more about that if you have an interest. And we also contributed to the Lancet Commission, and you may be aware of the Lancet Commission that came out in 2018. This is just quickly what some of the what the law requires and what the policy determines. And it's much in line with some of the work that we've already done, but we thought it was important both to codify pieces in law as well as to put it in national mental health policy. And this is not just the Carter Center, it's the entire mental health community that has contributed to that. I wanted to point out a few things to you in terms of the law and the policy that are important as in terms of our next steps. And one is the whole issue of inclusive education. By and large, children with developmental disabilities, physical disabilities, and certainly children with social emotional problems are often excluded from school. And so we've been working with the Ministry of Education to draft tools to ensure that we have mechanism for school inclusion for these children. For the past 5 years, even before Ebola, we started training school teachers around how to engage and incorporate students with disabilities into the classroom. This has been, post-Ebola, really put into high gear, and so we have been working on a number of strategies to support the inclusion of children with disabilities, to work on mental health in early childhood settings, in classrooms, and in different types of schools. Quickly about what the mental health policy and continuing about the mental health policies and laws requires is really civil rights for persons with mental health disorders, which didn't exist. People would be taken to places and chained in places for long periods of time because they had lived mental health experience. We also have embedded in the law the need for crisis intervention training and in the policy, as well as some of the interventions that we want to see going forward. This is just a snapshot of some of the specific MHGAP training we did for healthcare workers, so that you can see that it incorporates not just MHGAP and family psychoeducation, but have our healthcare workers that don't have specialized mental health training also have access to what do you do in the case of acute stress, grief, and loss. What do you do in terms of a referral pathway? What do you have to know around addiction, and what do you have to know about children who have started to experiment with drugs and alcohol? What do you need to know about affect regulation? And what do you need to know about the types of disorders that normally children are excluded from school for? So epilepsy, children with developmental disabilities, children who have had suicide ideation, often excluded from the classroom. So at the end, we trained 110 through our basic child and adolescent training, 101, through our basic child and adolescent training program, and have started, and you can probably Google and find some of the work that we've started to write up on that. And then since then, we've increased that number of child and adolescent mental health clinicians. This is just a snapshot around our brain science training. And again, you can find some articles. We've started to write articles on that. That has been with science teachers to train 101 science teachers, and now we're integrating it into the science curriculum at the teacher training colleges. And it's for science teachers to be able to start to introduce neuroscience in the classroom. And so children with lived mental health experience can start learning about themselves and how their brain works. And other children will start to understand how their brain works. And we've found, we're talking with the teachers, that children are really, students are really interested in this material. Our school health manual is something else that we've integrated into the teacher training curriculum. So pre-service, the teachers have some knowledge about how to work with children with mental health conditions. And the school health manual is a WHO intervention. You can pick it off online. What we did is we took it, we trained our teachers in it, and then we adapted it for the Liberian setting. Our training is now transferred to Zwedru, and which is back to the government of Liberia, and they are now, we're helping with the government to support 2 new cohorts, and so they have now embarked on that. And we've promoted, we're promoting with the government of Liberia how we can embed mental health and psychosocial services into the universal healthcare strategy that WHO is promoting for all countries. I've talked a lot already about some of the work that we're adapting. This is Thinking Healthy, which is another intervention that we're adapting to work with pregnant women and their young children. And we're adapting this for the Liberian setting. We're also working with WHO and with the Liberian government to adapt WHO caregiver skills training for the Liberian setting. And one component of that is that Liberia was recently invited with the Early Childhood Division at the Ministry of Education to engage in a learning and planning event at the Kennedy School of Government to help map out how we can embed mental health and psychosocial supports in our early care and learning setting. How can we begin to start tackling this from a very early age? I have to acknowledge the work that we have done with our partners, particularly the Ministry of Education, Early Childhood Division, the Ministry of Education and the School Health Division, as well as the Ministry of Health, of course, who are our partners in the Family Health Division. And one of the things that we're working on is transferring some of our the work that we have done to a C certificate program in early childhood development that, again, like the work we've done in health, we want to embed in the pre-service training. These are my co-conspirators, my co-workers. This work is not done only by me and our partners in the Liberian government, but also by my colleagues here at the Carter Center. Thank you very much. I appreciate the opportunity to talk with you all.
For sharing with us all the work that you've been doing with different professional and community groups and individuals in Liberia, and particularly the mental health services and support established in communities highly impacted by the Ebola virus outbreak. In the time we have left, we'll go through some questions. All the participants, please send messages through the chat box. And I will be passing the floor to you, Janice, after I formulate each question. I hope that works smoothly. So let me get started. So you and other institutions, other organizations have implemented capacity building, and we wonder do you think that these initiatives that appear to be based more on a biomedical approach have actually shaped the local ways of understandings of mental illness and help-seeking behavior?
A really, really good question. One of the reasons we've worked so hard to work with persons with lived mental health experience as well as religious and traditional leaders is because we really want the work we've done on the biomedical space to inform the work that the mental health and the psychosocial workers do with regard to social work and to psychosocial interventions. And all of the work that we do is informed by cultural adaptations of that work. So we start off with our PSS manual, and what we do is we sit with individuals who work in the space and the intersection between traditional medicine and community health, and the work that we do in mental health and health in the sector. So I think that and it's really, really important that we have that link, because at the end of the day, access to services depends on working together. There are many people in our country with lived mental health experience that can benefit solely from community psychosocial interventions. However, there are many also that need also to be able to access their medicines. And one of the things we find with persons with lived mental health experience is the minute that they start to feel better, they often want to go off their medication. And so one of the things that we've really worked hard at doing is to make sure that they understand that both the work that we do in the community, both the work we do at the traditional level, and even with religious, because we have a lot of individuals who believe that if only they pray, or they use holy oil, or they have an anointing, that their mental illness will go away. And indeed, there are cases where if they're working in the churches, they may begin to feel better, but I've yet to see a case of psychosis that goes away only through prayer. And so it's really important for us to make sure that they engage with their community and the background that they come from and the lived experience that they come from, and as well as engaging with accessing the services that they need from the healthcare system.
Now we have a question from Raluca. I'm fairly new to the field of mental health, so thank you for this webinar series. Thank you, Raluca. I'd like to ask, where are the biggest evidence gaps when we're thinking about mental health, especially in humanitarian settings?
Question. I think the biggest gaps really relate to the intersection between whatever the in the case, say, let's talk about disease outbreaks, and then I can also talk about post-conflict and natural disasters. But in the case of these disease outbreaks, I think one of the biggest gaps is, where have we looked at, especially from the perspective of the traditional and religious leaders, what are some of the interventions that they have that we could learn from and test? I think that's one of the biggest gaps. What we've worked with heretofore in Liberia from an evidence perspective is really, how do we engage traditional and religious leaders so that we practice the do no harm. But and a lot of what the religious and traditional leaders have to offer us is how they engage persons in general, the general population, including persons with lived mental health experience. I very early on, when I came back home to Liberia, I walked into a church, and at the very front of that church, on a pew, was someone with epilepsy, and he was lying there, and he was there because he believed that he could be cured and healed of his epilepsy. And so engaging religious leaders and traditional leaders who people see as the first line of defense is very key for me to be able to make sure that what they have to offer in the space can be tested, validated, and implemented.
Your presentation highlighted the important role of school-based programs to promote mental health. In many low and middle-income countries where resources are scarce, teachers may be less motivated or may find the intervention additional work unless they're provided with other incentives. Have you encountered those issues? And if so, how did you respond to these challenges, and how could you enhance sustainability of a school-based program?
Yes, so, and it's not just teachers, even healthcare workers sometimes, in our setting, sometimes healthcare workers go for months and months without pay. Teachers in Liberia have been going for many months without pay. So you're going to be less motivated to introduce these interventions. And so, and certainly when we are doing training of trainers, we provide incentives for those trainers to train other teachers. There are two things, and because this is now going on without any incentives on our part, but if you have been able to convince the teacher that if they have this knowledge, it makes their day go by better, it goes by faster, they're not confronting a lot of children because who they're not able to manage in the classroom setting. That has definitely been a motivation for the teachers that we've been working with. And in the neuroscience, it's been really, really interesting because we're now evaluating the teachers after they've been back into the classroom and they have started integrating it into their science curriculum. And it's fascinating for us to see their responses, because some of their responses is that I get through my training so much, my teaching so much quicker than I did before because I have a better handle on my classroom. I get across for children who I thought were failures, I am getting something out of them. So there is some intrinsic reward associated with this. Obviously, teachers need to be paid, and we've had cases where teachers have stopped working because the government haven't paid their incentive. But by and large, we see that the skills that we're giving to the teachers enhance their ability to work.
It looks like a range of WHO frameworks, guidelines, and manuals that you've used in the programs that you presented. On the other hand, there's social, cultural, and political context that seems to be quite complex in Liberia, and individual and collective suffering that is multi-layered. I wonder to what extent the complexity of the local context has been taken into consideration, and in what ways are those standardized manuals adapted for use locally, and specifically, can you provide examples?
Really, really good question. Again, that we spend a lot of time adapting the curriculum, the WHO manuals in particular, and what WHO says takes 5 days usually takes us 2 weeks, meaning 10 days of training, because what we're interested in doing is making sure that at a base level, there's an understanding of how you bring in and how you deal with the social, cultural, and as you said, political context. When we start training persons with lived experience around self-empowerment, and they recognize how they are portrayed in the media, what the landscape looks like when persons in public settings talk about quote-unquote crazy people. And so they are motivated to learn about their conditions, to learn about how they need to represent themselves in Liberia, and how they need to represent themselves in the public space. So we've been working with United for Global Mental Health, and our mental health service users are part of the United for Global Mental Health Global Anti-Stigma campaign. And so they are going out there and they are confronting the stigma. They are confronting the need to make sure that they are represented at all levels. And nothing about us without us is one of their slogans. And they are also very, very much aware of the need to make sure that they address stigma. So recently, they went to the House of they were instrumental in getting the law passed, the mental health law passed, but then they went to the houses of the legislature to push for budgets, and they were called all kinds of names. They were challenged about whether the leadership of our legislature wanted them to come to persons with lived experience as opposed to the other way around. And our persons with lived experience said, yes, we are your constituencies, and we will lobby and we will advocate that you don't deserve this job if you're not representing all of us. So I think it's really important that we work on stigma constantly. Stigma is not just a West African issue. We were recently at an international meeting of people from all over the world, and persons with lived experience confront stigma in all shades and forms all the time. And I think what keeps us honest as the Carter Center and as our partners working in this space are persons with lived experience. Honest from the perspective of representing their cultures adequately, and honest from the perspective of representing their experience adequately.
Inevitably, the question, what did you learn from combating the Ebola virus that can improve the response to the current coronavirus epidemic?
Yes, well, I think we learned a lot. One thing for sure, probably the biggest takeaway is that when you have this kind of emergency and people are literally dying around you, and not all of the people dying around you are dying from Ebola. They're dying because the healthcare system isn't working. And so one of the first things we learned is that in that midst, and the whole world sends people to help you, sometimes you need to have the helpers go outside the room and recognize that you need to think, people from that country, need to think strategically about how you're going to reach your people so that the fear-based behaviors can diminish and you can get to the business of addressing the virus. And that's what we learned. And I remember distinctly, we had during Ebola someone who was the president's special advisor. He was a social worker by profession. He was the president's special advisor to the incident management team that we all sat on. And he and the leader of the incident management team, at one point, when we had so many helpers we didn't know how to think, he asked everybody to get outside of the room besides the healthcare workers who were attached to the ministry and persons who were living and working in Liberia. And the idea was really about, listen, at the end of the day, all the helpers are going to go away and we're going to be left here. And so we can't be screaming at each other. We have to have a plan, and that plan has to be in concert with what our people need. And so one of the things that had been very, very clear is that people were refusing to go to the treatment units because oftentimes they never got word of what happened to the person that went to the treatment unit. So we hadn't put in place enough communication from the treatment unit to persons, family members who were left behind. And so if a family member got infected, for example, they had seen a family member go to the treatment unit and not come back. And so how could you make sure that you had communication between the two that fostered trust? Because that was what was missing early on. Community trust. We come in high and very heavy-handed with the biomedical response without building enough community trust. And you have to do that quickly because we're all confused, including the helpers. The helpers are confused because many helpers died. And so it was very important to continue to build the community trust. We had community healing dialogues right after Ebola because neighbors had been pitted against neighbors. Neighbors would blame one neighbor for having started the epidemic in their community. And so it was really, really important that not only did we integrate survivors back into their communities, which required community trust, but we made sure that those communities became whole again.
Way for the next question was about the community healing dialogues, actually, whether you could expand on those and whether young people were part of those dialogues as well as people with disabilities or with severe mental health conditions.
So for the CHDs, they were mostly not done with people under 18. Which is something that we could definitely learn from. But they were definitely done with persons with lived mental health experience, persons with disabilities in the communities as well. Yeah, so the idea was really to, the mental health clinicians have been pivotal to the response. And so they knew many places where communities had been fractured as a result of Ebola. They also knew many places, and we had many examples. I worked on the team that worked with survivors. And so I had many cases where the survivors we worked with could not go back to their communities. And so making sure we had those entry points so that survivors could go back to their communities. Their families often couldn't go back to the community. So there was really an effort to kind of bring back that social cohesion. And the only way you could do that was to continue to talk to people, understand that that we all had to come together and to work together.
The community healing dialogues, like what would it look like? Does it happen over time? Is it a one-time meeting where everybody's invited? Like, how can we get more information about those?
Community healing dialogues were anything from usually 10 to 12 weeks. Some were, some of the ones that WHO ran were maybe a little shorter. There's at least one publication that the WHO did on the healing dialogues that they supported. Yes, it was this idea of coming together, talking about those things that were most fracturing the communities, and talking about those ways that they could come back together. So, for example, one of the parties to a community healing dialogue was someone who was an Ebola survivor, but he would get up in the morning at 5 o'clock, and he would leave his house. He would not come back to his house until at least 6 or 7 under darkness because of the stigma, ostracization, and just the bad feeling in the community towards him. He was not allowed to use any of the public amenities, so he couldn't draw water from the well. And so there was just a lot of stigma attached to that. And we have many of our mental health service users who have lived experience as well as who were persons affected by Ebola, who will tell you that they would go to church and everybody in the pew would move away from them. They wouldn't take their money. And how many of you know churches that won't take money, but they wouldn't take their money? So we've come a long way from that in terms of the stigma associated with Ebola. And so the CHDs, the community healing dialogues, we did them with religious leaders, with traditional leaders, with community members, and the idea was really to use the trust that the communities have with religious and traditional leaders to try and turn the page.
When the political system is not stable, as we see in many low and middle income countries each time, when the political leaders change, their health priorities and policy can change again. So how's the situation in Liberia, and what kind of efforts are being made to sustain the outcome of the implemented programs and policies despite maybe instability in political context?
We have a history of civil war, so there is, we're, even politically, we're fairly fragile, and while we had 2 terms of some stability, we recently had an election, and we're in the 2nd year of a new administration. And the new administration, frankly, that has not had the same economic support as the old administration. So as I talk to you, we have long lines because there's not enough gasoline in the country. We have issues and concerns about whether there will be enough rice in the country because rice is our staple. So you know that kind of tense economic situation, and we have a whole lot of people who post-Ebola have not been able to get the same level of work they were getting during Ebola. Ebola was an economic boost as well because it ended up employing some people too. So we do, and then globally, as you know, we're in somewhat of an economic downturn, especially in sub-Saharan Africa. So all of those things make the situation particularly difficult. I think what we have, and then there's the whole mantra or overcloud, I should say, of what is happening with the coronavirus and whether that will come to Liberia. We have a significant number of expats that are from China, long ties with China and Liberia, and so we have some Liberians who have been in China and are coming back. And so you can imagine that there is some concern that if we do get the coronavirus disease in Liberia, we will be back on this trajectory again. That also heightens concerns for the general population. So many of our mental health clinicians are working, especially with persons with lived experience, but also in their practice in general, kind of talking to people about making sure that they stay healthy, making sure that they follow their health regime so that they can be healthy, both from a getting the infection perspective, as well as making sure that they do not become so fearful that they relapse.
I think we're coming to the end of our webinar. We're going to send a brief evaluation to the email address that you registered with, or you can copy and paste the URL that appears in this slide. It will take less than 5 minutes to complete and will help us greatly as we plan future activities. Finally, the recording of this webinar, both in English and in French, will be posted on the websites of the McGill Global Mental Health Program and other webinar series sponsors, whose logos you can see at the bottom of this slide. Thank you. Thank you again, Janice. Thank you to all for your participation. I wish you a good end of your day.